Thank you so much for joining us in this educational symposium on new perspectives in the multidisciplinary management of stroke associated with diabetes. My name is Geert Biessels, and I'm a professor of neurology in Utrecht, the Netherlands. We have an exciting program for you today, showing the latest developments in glucose management that are particularly relevant for secondary prevention also, and may even change your practice. Please let me introduce the other faculty to you, because we are very fortunate to have a lineup of experts in the field who represent the disciplines of neurology, endocrinology, and general practice. And these people have really been fundamental to developing trials highly relevant for diabetes management in people with stroke. Let me introduce Dr. Blanca Fuentes from Madrid, who is a neurologist, Professor Herzl Gerstein from McMaster University and Hamilton Health Sciences, Hamilton, Ontario, Canada, who is an endocrinologist and a general medicine specialist, and Professor Stuart Harris, who is a GP and an expert in diabetes management in family practice settings. These are the disclosures of all the speakers. The learning objectives today are that you, after this symposium, have know how to manage the acute hyperglycemia after stroke, and in particular, how to use the newer antidiabetic agents in stroke prevention. The idea is that you can use this information for individualized management of your patients, and realize how much the importance of the multidisciplinary collaboration in this setting. Likely you have seen the pre-module with lectures from Blanca and Herzl. If you not have seen it yet, you can still look at it. And Herzl and Blanca kindly give a summary of their lectures at the start of this symposium. After this, these presentations from them, we will have two case presentations that will be discussed with the faculty. And after this, we open up to you for live Q&A, and there will be polling questions along the way. This educational activity is accredited by several organizations, and the program has been made possible with an educational grant by Novo Nordisk. Let me briefly explain the voting system to you. There will be audience poll questions throughout the session for you, and you can answer those in the chat box on the right side of your screen. If you answer a question, please do click on the send button below, because otherwise your question will not be transferred to us. You can also, of course, ask questions to the panelists during the session via the Q&A box on the right-hand side, and you can already start asking your questions during the case discussions. And we would also appreciate if you could complete the evaluation form at the end of the symposium. So let's start with a first pre-assessment question. Which of the below antidiabetic drug classes has shown significant promise in the prevention of stroke associated with diabetes? 4 options. The first one, A, sulfonylureas, SGLT2 inhibitors, and GLP-1 receptor agonists. Second option, GLP-1 receptor agonist and TZDs. Option 3, GLP-1 receptor agonist, TZDs, and SGLT2 inhibitors. Option 4, DPP-4 inhibitors, GLP-1 receptor agonist, and TZDs. I give you some seconds to think about that. Please use the box on the right. And don't forget to push the send button. Okay, then I move to the next question. How confident do you actually feel in clinical practice with the appropriate use of antidiabetic agents for the prevention of stroke associated with diabetes? Are you very confident with that? Quite confident, neutral, not very confident, or not at all confident? And of course, we will treat your answers in strict privacy. Give you a couple of seconds to think about that, but you know how you feel. So I move on to the next question, and that is about acute management of hyperglycemia in patients with an acute stroke. Are you very confident with managing that? Quite confident, neutral, not very confident, or not at all confident? Okay, thank you for answering these questions. Let's move to the presentations now.
So Blanca and Herzl, you kindly agreed to briefly summarize what you so elegantly presented at the pre-module. Blanca, first, the floor is yours.
Thank you, Geert. Post-stroke hyperglycemia is a frequent complication in acute ischemic stroke, and it is a well-known prognostic factor. It is associated with poor outcomes independently of age or severity of the stroke subtype, and it counterbalances the beneficial effect of any of the recognition therapies, either intravenous thrombolysis or mechanical thrombectomy, because high glucose levels increase the brain reperfusion injury and the risk of symptomatic hemorrhages. However, clinical trials, which were mainly focused on the intensive reduction of glycemia to very tight glucose targets, had failed in the demonstration of any effect on a stroke outcome with a higher risk of hypoglycemia. There are several reasons that could explain the failure of clinical trials. Some examples could be the inclusion of patients without hyperglycemia, the gap between data from observational studies and the glycemic target in clinical trials, and the high frequency of hypoglycemic events with the intensive glucose reduction approach. But the good news is that hyperglycemia can still be considered as a modifiable prognostic factor, as several observational studies have shown. I have reviewed the current status of the management of post-stroke hyperglycemia in clinical practice, and I must say that it's really poor, because only 23 to 71% of acute stroke patients with post-stroke hyperglycemia receive insulin, and persistent hyperglycemia despite corrective treatment is very frequent, affecting more than 80% of the patients. There is a clear opportunity for improvement, and the advice and expertise from our colleagues from the diabetes file can help us in choosing the optimal target glucose range, the optimal insulin regimen, as well as the route of administration of insulin. They clearly recommend avoid sliding scale insulin as the sole regimen, and for critically ill patients such as acute stroke patients, they recommend the use of intravenous insulin infusion as the most effective method for achieving glycemic targets. And for patients who are stable and start feeding, we can use subcutaneous insulin regimen with basal, prandial, and correction components. And now I pass the word to Herzl Gerstein.
Thank you, Blanca. So to summarize what we've said before, there are a variety of ways to lower glucose levels, and there are classes of glucose-lowering drugs that have not been shown to reduce either cardiovascular or cerebrovascular disease. And you can divide those into two: those that cause hypoglycemia as a side effect, such as insulin or sulfonylureas or glycine drugs, or those that do not cause hypoglycemia, such as metformin, DPP-4 inhibitors, and alpha glucosidase inhibitors. Now, all those glucose-lowering classes have not been shown to reduce either cardiovascular and or cerebrovascular disease. Conversely, there have been 3 classes of glucose-lowering drugs that have been shown in well-done large trials to reduce either cardiovascular or cerebrovascular disease. The first are the glucagon-like peptide-1 receptor agonists. The second class are the SGLT2 inhibitors, And the third class are the thiazolidinediones. And these are the ones that I'm going to talk a little bit about a little bit more. Next slide, please. So here is a meta-analysis updated as of last April, a few months ago, of the seven glucose lowering trials, or pardon me, GLP-1 receptor agonist cardiovascular outcomes trials. And you can see that in this meta-analysis, the primary outcome for all these trials was MI, stroke, or CV death. And then other outcomes are listed there. When you look down the list, you can see that the biggest effect size for all the meta-analyzed studies together was on fatal or non-fatal stroke, where there was a 16% reduction of fatal or non-fatal stroke meta-analyzed from 7 large cardiovascular outcomes trials, compared to the other cardiovascular outcomes when there was about a 12% reduction, for instance, on MI, stroke, or CV death, or an MI alone was about a 9% reduction. Next slide. When you actually look at these trials according in a meta-regression analysis, looking at the degree of hemoglobin A1C effect compared to the reduction in stroke, you see that those trials in which there was the biggest reduction in hemoglobin A1C seem to have the biggest effect on stroke, suggesting that there may be a glucose lowering aspect of the benefit in addition to the use of the GLP-1 receptor agonist drug. And indeed, mediation analysis have suggested that there are 2 effects going on, the actual direct effect of the GLP-1 RA and the glucose lowering. Next slide. The next class are the SGLT2 inhibitor drugs. And here's a meta-analysis of 5 trials. And you can see when you look at these drugs together, there is a modest effect on MACE, which is a 10% reduction, a big effect at the bottom on heart failure hospitalization, and a big effect on a renal outcome, which reduces the decline in renal function. But as far as the effect on stroke, which is what we're interested in today, there is really no evidence of any benefit on stroke for this class of drugs. And then finally, next slide, if we look at the thiazolidinediones, and one of them specifically has been assessed in stroke, and that is pioglitazone. And you can see in 3 trials that have been done with this drug, there is a fairly consistent benefit of a reduced risk of stroke with the thiazolidinediones, and specifically pioglitazone, and altogether about a 30% reduction. Next slide. So in summary, next slide, glucose lowering with GLP-1 receptor agonists and pioglitazone show the most promise for stroke prevention in people with type 2 diabetes. Next slide. Their potential cerebral protective effects in people without diabetes is now becoming interesting and is going to be an area of study in the future. Thank you.
Well, thank you so much, Herzl, Blanca, for these elegant summaries. But let's bring this to practice together with the audience. And what I would like to do now is share some cases with you and ask for your expert opinion. And of course, we are going to query the audience as well. So let's first go to the emergency room where we see a patient who actually has an acute stroke. So this is a man aged 76 years, and he has a history of hypertension and obesity, no known history of diabetes. And he presents at the emergency room at 10 to 8 in the morning with a wake-up stroke, and he was last seen well at 10 the previous evening. And at the emergency room, he has an aphasia, a paralysis of his right arm and leg, and his NIH stroke scale is 23. Here you see his non-contrast enhanced scan with a dense vessel in the middle cerebral artery. On the left, you see a marked perfusion deficit on this time to peak image. And you see at the CT angiography the occlusion of the middle cerebral artery. Actually, with taking cerebral blood volume into account, there was a large penumbra still present in this patient. Next slide. So he's transferred to the angio room for endovascular therapy. In the meantime, his admission glucose becomes known, and it's 14 millimole or 252 mg per deciliter. And now here's the first question to you, the audience. Which glucose lowering therapy and which target would you recommend? Would you use continuous IV insulin, target 7.8 to 10 millimoles? Or answer B, continuous IV insulin, target 5 to 8 millimoles? Or sliding scale subcutaneous insulin, target 7.8 to 10? Sliding scale subcutaneous insulin, target 5 to 8? Or would you do something else? Answer E. Well, the right answer is actually answer A. And Blanca, may I invite you to comment on why this is the recommended approach?
Thank you, Geert. I will start continuous intravenous insulin as soon as possible in this patient, even before the transfer of the patient to the angio suite. High glucose levels have been consistently associated with poor outcome in patients treated with mechanical thrombectomy. The high glucose levels reduce the likelihood of getting good outcomes and increase the risk of hemorrhagic transformation and brain edema after mechanical thrombectomy. And the mechanism underlying this deleterious effect is the increase in the brain reperfusion injury. So it is very important that at the time of reperfusion, glucose levels be as better as possible. Indeed, in the SWIFT trial, for each 10 milligrams per deciliter increment in the glucose values, there was a 42% decrease in the likelihood of excellent outcome. Due to the lack of enough evidence on the glycemic target in acute ischemic stroke patients, since clinical trials were mainly focused on a tight target of glucose, I will follow the recommendations from the experts on the diabetes file that recommend the target range of 140 and 180 milligrams per deciliter.
Yes, thank you so much. And so your message is start as soon as possible, but don't delay your endovascular therapy because of this.
Of course, of course. We have time while the patient is transferring to the angio suite and all the endovascular procedure is preparing. We can start intravenous insulin. There is no delay for mechanical thrombectomy.
Yeah, thank you so much. And the relative risk that you show in relation, that you mention in relation to high glucose levels, really make the point that this is not a trivial action. So thank you. This is very important. Next slide, please. So after the endovascular therapy, the patient is transferred to the unit. And fortunately, there is actually a good recovery, and the patient will be discharged soon for clinical rehabilitation. And his A1C is 66 millimole, which equates to 8.2%. And now my next question to you, the audience, is what would you actually do next? Would you start metformin in this patient without a history of diabetes? Would you start a GLP-1 receptor agonist? Would you start a SGLT2 inhibitor? Would you ask the endocrinologist what you should do? Or would you refer the patient to the GP at home? So Blanca, may I ask you what you would do?
Well, this is a clear example of a patient with unknown diabetes. The values of glycosylate hemoglobin clearly support the diagnosis of diabetes. as they reflect the average mean glucose levels in the 2 or 3 prior months. Therefore, we should start a treatment of diabetes that include not only recommendations on the lifestyle behavior, diet, and exercise, but also we should start an antidiabetic drug. The first line antidiabetic drug is metformin, but in this patient, I will also consider to start with a GLP-1 receptor agonist due to the global vascular benefits that has been shown in the Herzl talk, as these type of antidiabetic drugs have shown a clear benefit in the reduction of stroke in patients with type 2 diabetes with established vascular disease, including a stroke. Indeed, in those trials, about 14% of the patients had a prior stroke. And we should not forget that diabetes is a chronic multisystemic disease, and we should also refer the patient to the endocrinologist or to the GP, depending on the local protocols, for the close follow-up of the diabetes and its complications.
Thank you, and it's important to hear this view from a very experienced stroke neurologist with special expertise in glucose management. But may I kindly ask Herzl what your take is on this?
I think the approach that Blanca described is perfectly reasonable and makes a lot of sense. I as an endocrinologist, think it's really important to spend a lot of time with a patient with a new diagnosis, discussing the diagnosis and educating them about that. And what I mean specifically is I always stress to patients that you have this disease, it's been there a long time, it's not your fault, you didn't cause it, but now you need to take care of it. And by taking care of it, you can prevent future serious health problems down the line. I think those are the most, in fact, if I had to say what's the only thing a newly diagnosed patient should be told is A, it's not their fault, but B, they have to do something about it to prevent future health problems down the line. If they just hear those two things, I think you're okay, but because it is a lifelong journey that they're now entering. So if an endocrinologist is available to be referred to, I think that's a great idea. Unless you have a system like it sounds like Blanca is doing exactly the same things an endocrinologist would do, which is great. You know, as long as you're doing those sorts of things. And as far as the drug therapy at this point is almost a secondary thing. You want to start them on something mainly to underscore that they in fact do have diabetes. This is not just a little sugar, but at the same time starting them on a road.
Yeah, so your point on the lifelong journey is very important, and often this journey with regard to diabetes will not be monitored by a neurologist. So transferring care actively to a GP or endocrinologist to really help the patient with his journey seems like a very important choice and recommendation. Thank you. Right. So the next slide, please. So Blanca, if the A1C of this patient who was clearly hyperglycemic in the emergency room, but if his A1C was 46, would that change your earlier recommendation on treatment?
This is a bit different situation. This patient could be diagnosed with pre-diabetes. And this means that this patient is a high risk for developing diabetes in the following years, but also it is in a high risk of stroke recurrences and other vascular events. Therefore, we should diagnose this patient. We should talk with this patient, explaining all the risks, and probably we should recommend some changes in the lifestyle behavior, diet, and exercise. And regarding antidiabetic drug, probably Herzl is going to give us the opinion. From the neurologist point of view, we could consider to start with pioglitazone according to the IRIS trial. that was developed in patients with a stroke or TIA and pre-diabetes.
Yeah.
It has shown a clear benefit on the reduction of myocardial infarction and strokes.
Yeah, thank you so much. So here your message is, with this A1C, and this A1C actually has added value over the glucose levels, and guidelines do recommend that you control this A1C, that you check this A1C. So in this case, the interpretation would be it was an acute stress hyperglycemia in a patient in pre-diabetes, and also this pre-diabetes needs some form of monitoring and, like you say, possibly even drug treatment. Herzl, would you have another take on that?
Yeah, it's really a point as to whether they actually have or don't have diabetes. Using hemoglobin A1C criteria, this wouldn't be diabetes. With their glucose, the stress hyperglycemia, you could say, well, if you really wanted to prove it, you could also do a glucose tolerance test, but that's not the issue. It's like saying, if somebody has a blood pressure of 139, do they have hypertension? If you're calling 140 hypertension.
Yeah.
There is a continuum of risk between your hemoglobin A1C and your future risk of serious health problems. It does not suddenly disappear at 6.5 and goes to 0 at 6.4% hemoglobin A1C. So all of the risk reduction strategies that you would consider are fine. Many payers will not pay for diabetes drugs. However, if you don't have a formal diagnosis of diabetes. So you could certainly, but it's a good time to tell people, look, you are at high risk for diabetes. With an A1C of 6.4%, your risk in any year is more than 10%, per year of developing diabetes. But it's a time to talk about lifestyle therapies. In many jurisdictions, you could add a drug like metformin to reduce future risk of diabetes. And, depending on what happens in various jurisdictions, certain drugs like GLP-1 receptor agonists might get indications for obesity. And then that becomes a different discussion than your quote, treating obesity versus not. But I think it's a good chance to say, look, we know that you're at risk for something. Let's reduce your risk. We'll also be reducing your glucose levels. That will reduce your risk of kidney disease, eye disease, other things down the line too. And we can then keep, surveillance and other things. So that would be the approach to take.
Yeah, thank you. So next slide. So I think this is a wonderful illustration of how all the evidence that was reviewed earlier really translates to practice, and it also shows how things has changed over the past years, because these case discussions have been very different 10 years ago. So there's really a lot to gain with the new knowledge, and you as an audience will have plenty of opportunities to engage with us in discussion of these cases. So put your questions in the chat, please. Let's move to the next case, please. And this is more on, say, chronic management. Here we're looking at a patient who visits a TIA clinic. And this is a woman aged 68. And she has a history of peripheral arterial disease, hypertension, obesity, and type 2 diabetes. She's on aspirin, enalapril, and metformin. And yesterday evening, she had an event lasting 10 minutes of acute dysphagia with weakness of her right face and arm with complete recovery. And she comes into the outpatient clinic. She gets an MRI, shows no diffusion lesion. Vascular examination shows no carotid stenosis, and there's no arrhythmia on the ECG. So next slide, please. She's already on aspirin, enalapril, and metformin 3 times 500 mg per day, like I told you. So you add clopidogrel, and her blood pressure is 142/78. Her A1C is 74, which translates in 8.9%. And now my question with regards to glycemic management to you, the audience, is what would you do? Would you increase metformin? Would you add insulin as an to lower glucose? Would you add GLP-1 receptor agonist? Would you add SGLT2 inhibitor? Would you ask the endocrinologist again, or would you refer to the GP? And Herzl, may I ask you what you would recommend in this case?
Yeah, these to me are obviously quite scary patients because I always worry that they're going to have a stroke, and so the idea of obviously the neurologist assessment is really, really, really important. If somebody's got an A1C of 8.9%, you know that their sugars during the day are running in the teens, that they're having sugars of 14, 15, 16, postprandially, etc. I mean, it's not that hard to make that inference, which means that they're going through the day. That affects your quality of life. It also means that you're somewhat dehydrated during the day. Stress hormones are going up, and so this is a reason to get the glucose under control. And the most reliable way of getting the glucose under control is to start insulin. And you can now, just because you start insulin today doesn't mean you can't stop it. 6 months from now or 3 months from now, insulin will work. It will lower the glucose levels, and a basal insulin injection will certainly work. And then that can be followed shortly afterwards, after they're starting to respond, with a drug such as, if I had to use another drug after that, I would use a GLP-1 receptor agonist. I'd start with insulin, get the glucose under some control, have the patient come back, and then add a GLP-1 receptor agonist, assuming that they have coverage. Pushing up the metformin is not going to do anything. At 1,500 milligrams a day, they've got most of the benefit of metformin already. Going up to 2,000 doesn't add anything. An SGLT2 inhibitor is not going to do anything for a cerebrovascular effect. So my inclination would be to do B followed by C in this situation.
Yeah, thank you. And actually, not all neurologists will feel possibly 100% confident with this, but what you are saying, this is a call to action. Something needs to be done. If you have the expertise yourself, make the right drug choices, but if not, and that's perfectly acceptable, do refer to somebody who is dealing and helping this patient to deal with the diabetes, right? That's the message.
I could add that if a neurologist didn't feel comfortable with adding insulin, and I can understand that because there's worries about hypoglycemia and titration. So if you're not comfortable with adding insulin, it would not be wrong to put this person on a GLP-1 receptor agonist and then refer them to an endocrinologist, for assessment afterwards, and then a decision can be made down the line. That would certainly be a perfectly acceptable approach if you're comfortable with adding the GLP-1 receptor agonist.
Yeah, Blanca, may I ask your opinion on this case?
I completely agree. From the neurologist point of view, as I also work in a TIA clinic, neurologists are quite engaged with the prescription of antiplatelets to control the blood pressure and also control the lipids, but we are not so engaged with the management of diabetes. And the problem is that if we are not engaged with this, we are not referring the patient to endocrinologists, and we're missing the opportunity to reduce the vascular risk of those patients. There are several interesting studies showing that in patients that have had a stroke and the antidiabetic treatments, we don't use to modify the antidiabetic drug, but we don't either refer the patient to the endocrinologist or to the GP to take care of the diabetes.
Yeah, thank you. So again, you say this is a call to action, and many of you may have seen that in the American Heart Association, American Stroke Association guideline, actually there's now a recommendation that a patient like this should have glucose lowering agent with proven cardiovascular benefit. So it's really important that that you get this patient to the right expert if you don't have the expertise yourself. It's a call to action. Next slide, please.
By the way, I'll just add that if the neurologist does add something, that is almost a guarantee that the family doctor or somebody else will refer them to an endocrinologist as well. And it tells the patient this is something serious that needs to be dealt with. So that will help that from happening.
Well, let's change the story a little bit, Herzl. What if the A1C of this patient, well, the color is red, but it's in the less red, it's in the more green range. What if it was 7.4?
Well, I think then you're not worried about, serious hyperglycemia during the day, and the person's control is not awful. And then adding a GLP-1 receptor agonist in this case could very likely push it down another percent. It also, by the way, drops the blood pressure, which is good. You want to do that in this situation as well. It's not a huge blood pressure effect, but there's a benefit is there. So I think in this situation, there'd be no question GLP-1 receptor agonist would be the drug that I would add, even in the hospital.
Yeah, very clear. Thank you.
Yeah.
Thank you to the audience for attending. Thank you for asking your questions and engaging with us. You can ask further questions along the way in the chat, but first question I would like to address to Stuart Harris, because the first patient with newly diagnosed diabetes after an ischemic stroke, the poll question to the audience came back that over 50% would start with metformin in this case. Then the patient is, of course, referred back to your care. What would you do, Stuart? Would you leave it at that, or would you change things?
Yeah, so I think just to echo some of the comments during the discussion from Herzl and Bianca, I would. This is a patient that shows up in my office one day, and I'm quite anxious knowing that they've already had a stroke, and I don't want to sit on them. Of course, we want to make sure lifestyle interventions are in play, and that's part of their package of care. But I also am not confident that metformin will get them down to target, and want to be quite aggressive in introducing, ideally, stroke risk reduction, glycemic lowering therapies. And this would be an ideal scenario to get that patient started on a GLP-1 RA, ideally that day. We usually we initiate our weekly GLP-1 RAs in the office setting, to help the patient gain confidence. It's not a big deal to use the pen, and you're already starting the treatment program, and you build your conversation and confidence building around the importance of getting glycemic control with a proven agent that will reduce their future risk, because you have their attention. And they are most likely going to follow whatever you say because of the event that they've just had to experience.
Yeah, thank you, Stuart. And I think the exciting point is that if I had asked this question to you 5 years ago, the answer would have been quite different, right?
Very different. And we, for the first time, we really have agents with proven future cardiovascular, in this case, stroke risk reduction strategies that the strongest signals, as was shown in the data, is really along the stroke risk reduction in all of the MACE in the meta-analysis. So yes, totally
different. This is, of course, why the latest guidelines, for example, from the American Heart Association or the American European Diabetes Associations, recommend us to do so.
Yep.
Another question is, I guess, and it came up several times in the chat, and I guess it's to Herzl and Stuart, and you can decide among you who will answer. But what is most important now, getting the A1C down or picking the right agent? Herzl?
We're going to say the same thing, I'll bet. Picking the right agent. Okay. And actually, if you choose a GLP-1 RA, you're going to get the A1C down quite effectively as well with that, because they're quite potent glucose-lowering agents. But really, the call to action is reduce future risk, secondary prevention, and choosing the right agent, I think, is the most important thing to do here.
Yeah, I would just make one important addition. No, I totally agree with Stuart. The only addition is it's not a license to ignore the A1C. So the right agent and having the patient stay at an A1C of 8.5% is not acceptable. If they're not well controlled, you need to get their glucose down to a safe range with respect to their eyes, their kidneys, and their quality of life. So yes, you need to have the right agent in play, but you do not ignore, significant hyperglycemia. And certainly with A1Cs above 8%, you need to get them down into the 7% range.
Yeah. Totally agree.
I have a second point related to this. Blanca commented on the patient with pre-diabetes that she was going to start a TZD pioglitazone based on the results of the IRIS trial. Stuart, if the patient came back to you with or without pioglitazone in this pre-diabetic state, what would you actually do?
Well, I mean, we have the one trial showing that there is a benefit with secondary prevention in the pre-diabetes patients from our study, but TZDs are not widely used in practice and in many locales, not even accessible. Even here in Canada, they're very hard to prescribe. So I think they've fallen out of favor in primary care, especially. So it's unlikely that a TZD would be chosen. And again, as Herzl mentioned in his discussion, I see the continuum risk around the dysglycemia, and I would initiate a GLP-1 RA here because it will also complement the lifestyle strategies around weight reduction that you're trying to encourage the patient, and they will gain benefit around some weight reduction, which will help their prediabetes. But you've just identified somebody very early on that's likely going to be diabetic. Maybe next time you see them, if you recheck the A1C.
Yeah, so you would just start, and do you have a program or a fixed way of monitoring people if you wouldn't start a treatment, or you would start a treatment anyway?
Well, I would start a treatment because again, you have a unique opportunity with that first visit post-stroke where the patient's scared. And will more likely follow your recommendations than just a routine patient with prediabetes. And so I think there's a great opportunity to intervene and get their attention and get management underway. And remember, in primary care, we get to see them a lot more frequently than you generally do.
And if I may tease a little bit, I mean, you are an expert on diabetes management. Your expertise is at the forefront of the field in GPs. Is this a widely held approach in the GP field, or are your colleagues still more conservative in this?
I think, when it comes to GLP-1s, RAs, for example, the uptake has been relatively slow in spite of, very pronounced and well-positioned GLP-1 recommendations in the guidelines. So I think it's one of the key take-home messages, I think, for the audience is you now have some exposure to the evidence. And if you put in your clinical note, would suggest consideration of a GLP-1 RA or a TZD, that's more likely to push the primary care doc to initiate that therapy. So I think even though you may not be comfortable starting it in your clinics, making that suggestion in your consult note to GPs is very important.
Yeah, but because I think that if we look at the slides that Herzl showed with a relative risk of 0.84 for the GLP-1 receptor agonist, I mean, that is compared to some of the other drugs we prescribe for risk reduction, a substantial effect. So point is well taken. Yep. May I switch to Blanca? Blanca, in the polls that we got in from the audience, actually over 70% of the respondents preferred a sliding scale insulin subcutaneous insulin regimen in the acute stage of stroke, and this is not completely what you advised. Can you explain again a little bit on the difference between sliding scale and continuous, and why really continuous is preferred?
Well, this is a problem on how we, the neurologists, manage the post-stroke hyperglycemia. I think that the difference or the deleterious effect of sliding scale insulin maybe be better explained by Herzl, if you don't mind.
Yeah, sure. Herzl, the floor is yours.
So the reality is that sliding scale insulin never works, or almost never works. And the reason it never works is because it is a response to something that's already happened. It's not anticipating things, and all it really does is makes the doctor feel better that they think they're doing something about the person's glucose levels.
But Herzl, maybe some people may not even know exactly what a sliding scale.
Yeah, so a sliding scale, there is no guideline anywhere that recommends sliding scale.
No, but what it actually is.
So what sliding scale insulin is that if you measure the glucose levels every 4 hours, and if the glucose level is above, if it's between 7 and 10, or up to 180, let's say between 150 and 180, give this many units. And if it's between 180 and 220, give this many units. I mean, it just doesn't work, and if you look at glucose control in people on sliding scale insulins, it's not good. And you're not achieving anything other than not being called by the nurse because the glucose level is high. If your goal is to have reasonable glucose control in the peristroke period, with glucose levels between 7.8 and 10, which is 140 to 180, then the only way you can do it is by infusing insulin in a way, and then adjusting the insulin infusion to keep the glucose levels in that range. Now, there are, in some places, computer programs that can actually adjust the insulin rate based on the glucose levels in a much more responsive way. And you can actually have variable insulin dosing according to the glucose levels in somebody on an insulin infusion. But that really isn't a sliding scale. It's an algorithm that's being developed and validated that adjusts an infusion of insulin. But when you're trying to do that with subcutaneous insulin, which is what sliding scales are attached to, there's variable absorption of insulin. The effect is lasting 2 hours, lasts 2 or 3 hours after you give it. It always underdoses insulin, and you never achieve what you're trying to achieve. So if your goal is to keep a glucose level in a range, use an insulin infusion and adjust it accordingly, either with a validated variable insulin approach or by doing it manually, which means you're being called that the sugars are above a range and you're making adjustments based on that.
Yeah, thank you. And just to follow up on that, the recommendation is for the higher range, so the 7.8 till 10 instead of 5 to 8, because the lower range is associated with a higher hypoglycemia risk. And this is...
Yeah, I mean, there's no evidence to push the glucose levels down. I mean, there have been studies that looked at it and it doesn't show benefit, right? So until there's better studies that show maybe it was the way it was achieved, I think it's conservative approach to say 7.8 to 10 for now. At least you're avoiding hyperglycemia, removing some of the huge effect. If there is a benefit from 5 to 7, it's probably small compared to getting the sugar less than 180 or less than 10. So I think it's a reasonable place to aim at this point in the acute period, not in the chronic period.
Yeah, and Blanca, you have been pushing this field in stroke neurology of the acute hyperglycemia, conducting trials. Can we expect any developments in the near future? Is there a hope? Is there light at the end of the tunnel?
Well, do you mean regarding
new trials, new approaches?
I think it's difficult to develop new trials in post-stroke hyperglycemia. One of the reasons is that we need a large sample size. Indeed, the Geert trial make a calculation on how many patients should be included in a trial to obtain significant results, and it was more than 2,400 patients, and the majority of the trials conducted to date were under 1,000.
Yeah.
Except for the SIGN trial that was 1,100 more or less. But the other important issue is the ethical issue of the control group. How we define the control group. We let patients with hyperglycemia already knowing that this is going to be associated with poor outcomes in those patients. So I don't see any other randomized clinical trial in this file. I will say that we have to look at the observational studies that have clearly shown that if we control glucose levels within the first 48 hours or 72 hours, we are going to reverse the deleterious effect of hyperglycemia and stroke outcomes. I have participated in the GLIAS study, that is a multi-center study in Spain, in the stroke units, and we identify as the threshold associated with poor outcomes was 155 milligrams per deciliter. And over the, any value above that threshold was associated with a two to threefold risk of
poor outcomes. Yeah. Well, thank you. So people should really refer to the guideline, the ESO guideline that you authored on this topic, and no major changes expected there in contrast to the secondary prevention. Another question, and I guess that's for Stuart, that comes up. So the audience sends congratulate you with a beautiful session and interesting discussion. But what pops up is that we have been speaking a lot about drugs, but they would like to hear a little bit more about weight reduction, dietary intervention, lifestyle. Stuart.
Yeah, so of course, that's always the cornerstone in any patient with diabetes or high-risk individual with obesity. If this patient, if these cases didn't have diabetes, and as I mentioned, you have the patient's attention. So this is in a post-hospitalization visit. This is an opportunity for one of those aha moments. I'm really going to take it seriously now. And if you're in a primary care setting or a setting where you have access to a supportive team like a dietitian or certified diabetes educator that can help work with the patient on strategies to reduce weight. But we're in a new era as well, because we have obesity drugs that quite significantly help patients reduce their weight. Coincidentally, they happen to primarily be within the GLP-1 RA class. So the scope of applicability of this class of drugs, especially for patients with diabetes, well entrenched in guidelines, but also in patients without diabetes, there's an opportunity to have therapy to support the lifestyle intervention. And I would add that, in our experiences where patients go on these medications, it kind of allows them and gives them confidence to further pursue their lifestyle strategies. They see some weight loss, and that reinforces their lifestyle strategies that they've undertaken. They feed each other, or not feed, but they support each other as effective strategies to
we heard very well that you used the word cornerstone here, right?
Mm-hmm.
Yeah,
absolutely, always. And throughout the patient journey.
Yeah, and another question to Herzl. You have been instrumental to many important trials in this field, and can we expect any further cardiovascular outcome trials in diabetes that are very relevant to stroke neurologists? Is there ongoing activity?
Oh, yes. There are ongoing trials right now of other GLP-1 receptor agonists for weight reduction, and their outcomes trials. And they're also going to be assessing, cardiovascular and cerebrovascular effects. And, it's also very relevant. There is a signal based on animal studies and an analysis of the Rewind GLP-1 receptor agonist trial that these drugs may have beneficial effects on cognitive dysfunction and cognitive decline. There is a program that is assessing the role of these drugs in people with MCI, moderate cognitive impairment, or people at high risk for dementia and things of that nature, as well as another program in Parkinson's. So there is a whole range of possibilities, and some of these outcomes are being assessed, and things that are very interesting to neurologists and everybody else, and patients are certainly being assessed. So I think there's a huge future for drugs like the GLP-1 receptor agonists. There are now drugs that are dual agonists that have more than GLP-1 effect associated with them and lower glucose and weight, and even more, and they're being assessed in outcomes trials. So this area is a huge growth area. And
okay, I'm a bit of an outsider, but as I understand it, the previous cardiovascular outcome trials are pushed by the FDA because of safety concerns, and those have dropped off. But that generated huge trials with long follow up with many outcomes. If weight loss is the primary outcome, will we be powered to see anything meaningful on stroke?
No, so some of the trials are actually using the drugs in people without diabetes, assessing weight loss, but also assessing outcomes as well. And some of the trials were done only because of the FDA guidance, but there are other trials that were done before the FDA guidance and some after the FDA guidance has now changed. And the companies that are actually stepping up to the plate and are doing the right thing without being told by a regulator. And the right thing is to assess the effect of drugs on outcomes that are relevant to patients, not just market the drugs. There are those studies going on right now. And, regardless of what a regulator says, they have to be done because they're going to be the reasons that we prescribe these drugs. So
exciting times.
Yes.
Well, I have the final question to all three of you, because this has been a marvelous session, but is there a question that the audience should have asked you? The $1 million question that should have been asked because this point should have been made, or because I think they have been very comprehensive in the things they put forward, and I don't see any acute raised hands. So then we are moving towards the post assessment. So I thank the audience. I hope that you have found this useful. For me, even though I'm interested in the diabetes field, I learned a lot. Some of this is really new to me, and I think this is going to change practice. So do watch the pre-modules if you haven't done so. And can I ask for the post-assessment questions to be shown? So I'm going to repeat the questions that you have seen before. Which of the, and you already start voting, I note. I'm not going to reread everything. The agents are now familiar to you. So take some time and look at the classes here.
Remember to press send.
Remember to press send. That's an important additional comment. And actually, we do see a shift in the answer here, because more people have voted for the preferred answer, and that's the one on top. And other answers like the one below shifted, for example, the lowest one shifted, for example, from 33% to 0. So this, it appears that this has been a useful exercise. Let's move to the next question, please. So your confidence on choosing the right agent, how is that now? So the responses are coming in. Do please press send. And I'll give it 3-4 seconds, and then we will move on. And this, and I'm very glad to see this, because this has shifted considerably. We were before more in a Gaussian curve around neutral. So I'm glad that this is apparently has been useful for you. So the final question, next slide, please. Is on hyperglycemia in the acute phase of stroke. How confident do you feel now after the discussion, after addressing the guidelines that exist? I give it 3-4 seconds, but I think that people are now moving from also from this session possibly to other sessions. So may I please, and that is the final slide, thank you for your attendance, and remind you, yeah, you can switch to the final slide. May I thank you for your attention. May I thank the faculty for their participation. This is very much appreciated. You rarely have a lineup of these people together, really the experts on the topic. So thank you for being with us, and thank you the audience for your active participation and your interest in this session. Thank you.